Hello, my name is Jocelyn Downie, and I'm the James Palmer Chair in Public Policy and Law and a university research professor at Dalhousie University in Nova Scotia, Canada. I've been involved in assisted dying for many years, including, for example, being on the plaintiff's legal team in the Carter case, which we'll talk about in a few moments. All right. With that, let's get going on an overview of assisted dying in Canada. In this overview, I'm going to review the journey to Canada's MAID legislation. I'll define some key terms and explain our eligibility criteria, at least until March 20th, 2021. Trudeau-Lemons will cover the imminent changes. And then I'll give some data on our experiences in Canada to date and share some learnings from our experience. So first, the journey. This starts with Carter v. Canada, a decision from the Supreme Court of Canada in 2016. The court found that the blanket prohibition on assisted dying breaches the Canadian Charter of Rights and Freedoms, specifically for persons with a grievous and irremediable medical condition causing enduring suffering that is intolerable to the person, where irremediable does not require that the person undertake treatments that are unacceptable to them. Later that same year, the Alberta Court of Appeal clarified a key point from Carter, finding that persons with a psychiatric illness are not explicitly or inferentially excluded from the Carter Declaration if they meet the criteria. Now, in response to the Carter decision, the federal government introduced and the federal parliament passed Bill C-14. This change to the criminal code removed the blanket prohibition on MAID, as per Carter, but it narrowed the eligibility criteria. Under the legislation, there are 6 main eligibility criteria. You must be eligible for government-funded health services, be at least 18 years of age, be capable of making decisions with respect to health. It must be a voluntary request for MAID, not made as a result of external pressure. You have to give informed consent to receive MAID after having been informed of the means available to relieve the suffering, including palliative care. And finally, you must have a grievous and irremediable medical condition. And here's where the narrowing happened in the 4-part definition of grievous and irremediable condition. To have a grievous and irremediable medical condition under the legislation, although not under Carter, you must have a serious and incurable illness, disease, or disability, be in an advanced state of irreversible decline in capability. The illness, disease, or disability or state of decline must cause enduring physical or psychological suffering that is intolerable to the person and cannot be relieved under conditions that they consider acceptable. You must also have reached the state that your natural death has become reasonably foreseeable, taking into account all of the medical circumstances without a prognosis necessarily having been made as to the specific length of time that they have remaining. And I note that that awkward wording is actually from the legislation. That's not my explanation. So that is our journey to legislation. Now to explain the meaning of some Canada-specific terminology. We use the expression medical assistance in dying, or MAID, and included in this is both provider-administered assisted dying and self-administered assisted dying. We also have this phrase, natural death has become reasonably foreseeable. And this has come to mean several things. It can be sufficient temporal proximity, and that can be multiple years of prognosis, or you are on a predictable trajectory toward death. So for example, on the day of diagnosis with ALS, you are now on a predictable trajectory, or it can come from the expression of a certain intent to stop preventive care and refuse treatment. So for example, the clear intent, the certain intent to stop using a BiPAP machine required to prevent infection, and an intent to refuse antibiotics when the inevitable infection ensues. With that, then, here's some key data illuminating the situation in Canada. This official data actually takes us to 2019. It includes the 2019 data. Unsurprisingly, for a new intervention, the numbers are rising. In 2019, there were 5,631 MAID deaths. There is variability in the percentage of total deaths attributed to MAID in different provinces in Canada. The range is from 0.3 to 3.3%, and the Canadian average is 2%. The leading condition prompting MAID is by far cancer at 67.2%. Relevant demographics that we have available include that 50.1% of MAID cases are men and 49.9% are women, and the average age is 75.2. You can see the distribution across ages here, and I would note the largest group is the 65 to 70-year-olds. Now, the nature of suffering of those who received MAID is as follows, and I'll just tell you the ones, I'll flag the ones that are over 50%. The loss of ability to engage in meaningful life activities, 82%, loss of ability to perform activities of daily living, 78.1%, inadequate control of symptoms other than pain or concern about pain, 56.4%, inadequate control of pain or concern about it is at 53.9%, and loss of dignity comes in at 53.3%. It's important to note access to palliative care and disability support services. Especially note that 89.6% of people had access to palliative care if it was needed, and only 3.9% required but did not receive disability supports. We also have data on the reasons why people were found to be ineligible for MAID. And these include, they're not capable of making decisions with respect to health, 32.2%, natural deaths not reasonably foreseeable, 27.8%, they're not in an advanced state of irreversible decline in capability, 23.5%, not experiencing suffering that is intolerable to them, 17.7%, they couldn't provide informed consent, 17%, they didn't have a serious and incurable illness, disease, or disability, 13.3%, and the request was not voluntary, 1.6%. So that's the data. Now let's look at the learnings. First, learnings from our mistakes. Define your terms. For example, reasonably foreseeable was not defined in our legislation, and so there was lots of confusion and controversy, and as a result, barriers to access, where people misunderstood it to mean terminally ill or a 6 or 12-month prognosis, which is not what it meant. The second learning, be clear on your rules in advance about conscientious objection, individual providers and institutions. So, for example, whether there is a duty to refer or a duty of effective transfer of care on clinicians, and whether faith-based institutions or philosophically oriented, i.e. palliative care entities, must allow MAID within their walls. The third is to ensure that the required drugs are approved and available. After C14 was passed, we discovered that secobarbital, which is the drug best known for self-administration, was not available in Canada. Now, we solved this problem, but it did create delays in access. The second set of learnings from mistakes include the need to be clear on whether clinicians can inform patients about MAID without being asked. And second, we learned that the requirement of express consent immediately prior to provision leads to people accessing MAID earlier than they otherwise would. Now, not all the learnings are from mistakes. Some things went very well. I would note that clinicians will step up and build community to share best practices and support each other. That it's good to have physicians and nurse practitioners able to assess and provide MAID, because both have the necessary professional competencies, and having both improves access because it increases the number of assessors and providers. Also, our eligibility criteria, except for reasonably foreseeable, they've worked to protect autonomy and prevent suffering without allowing for access to MAID where not free and informed and made by a competent individual. A few more lessons about what went well. There's been no slippery slope. And patients and their families have benefited greatly by the availability of MAID, both because they get comfort from knowing that it's there, even if they don't ultimately use it, and also because some of them access it. So that's a whirlwind tour, a whirlwind introduction to Made in Canada through a review of my 5 assigned topics: the journey to legislation, country-specific language and terminology, the eligibility criteria as of March 20th, 2021, the data that we have, and the learnings from our experiences. I look forward to talking with you later.